All right. Good morning, everyone. Thank you so much for being with us. We're just going to let people get into the room here. BJ will be joining us in a second, and Tom is here with us this morning to talk about when yes becomes no. And Tom, you can talk a little bit more about that since this is your beautiful creation. Um, I will quickly now go through the how-to on this end, and then Tom, we can get started with you. So just a refresher for anyone who wants to ask a question or has a comment, you can do this in two ways. You can click on the raise hand button and we'll unmute you and you can speak with Tom and BJ. And if you'd prefer not to do that, you can type it into the Q&A and I will read it aloud for you and they will respond to your question. The chat is also open, so please feel free to put any thoughts or comments in there as we go along. And thank you again for being here. Tom, I'm going to turn it over to you.
Uh, Thank you, Sonia. And take me back to when yes becomes no for a moment.
Absolutely. There we go.
Uh, Good morning, everyone. I'm so glad that you could be with us today. BJ will be joining us in a while. This is a talk that's been kicking around in my head for a little while. And hopefully some of you who are attending or are watching this have seen other talks that I've given with BJ through mental health on hope and denial and multiple loss and courage. And today's talk's a little different than some of those because those are often very I've review a lot of the literature associated. What I want to do today is have a more experiential talk. I plan to present a number of lovely, lovely people that I'm working with and some of the experiences they have been going through in deciding how to treat their illness or their disease. And so I titled this talk When Yes Becomes No, but really it's also when no becomes yes, or when maybe becomes I think so, or when I don't know becomes no. So it's just what we're talking about here is changing the plan that you had for addressing your condition, your illness, your diagnosis. So that's sort of where I'm going with this. Um, and what I want you to know at the start of this is that this is not a presentation on medical decision making. There are entire theses and books written on that, deciding how to make choices and decisions. There are MBA programs about that. What this is going to be is case examples and discussion about real life conflict that comes about when you make a plan of care to treat your illness and maybe you shift in that plan of care. So there's BJ. Greetings.
Mhm. Hi, Tom.
I was
Thank you
just
for your
setting the
input. Jumping
stage.
in.
Thank you. I'm glad to have you. Feel free
Mhm.
to speak up as we move ahead. We can move on to decision making, Sonia. All right. So decision making. This is obviously when you're processing what to do with new information. For example, you get diagnosed with a terrible illness, and you are trying to figure out what to do. You receive a lot of information early on in your diagnosis. You receive information from your medical team, from online searches, from the literature, but you also get information from your family and friends, and you also get information from your body telling you sort of what I need and what I want and how I'm feeling. So I just, you have a new event, there's a bunch of information coming at you, and you're asked to decide and to focus on a plan of care. How do I move ahead? Maybe that plan of care is to aggressively pursue treatment. Maybe that plan of care is to enter a drug trial, or maybe to decline treatments. So I just wanted to frame that decision making early on in your diagnosis is one thing, and decision making later in your diagnosis can become another. And that's some of what I want to talk about. So next slide, unless there anything, BJ.
Well, I know where you're going. I love where you're going. I will be mostly listening to you today. But just as we're going, there's so much as ever. The subject's big. And so to note, as Tom was just mentioning a moment ago, those internal factors, hearing your own voice, hearing the voices of others, how to process that information, how to take it in, how to feel it at all, is a big, big subject that we're on this talk going to sort of jump over the mechanics of that to something different. But I just want to note as we go along here, there's some things that in this talk are sort of a bullet, but that are worlds unto themselves in this process.
Yeah, each of those bullets could be entire hour discussions.
Right.
Um, like the factors affecting your decision. And so we've touched on some of these. There's your prognosis and your severity of diagnosis. They're what the available treatments are. They're the impact of the treatment on your body. There's reasonable outcomes that you can expect. But there's also, that's kind of the medical component. But what BJ was alluding to, there's also your history and how you have dealt with bad times or hard decisions and choices. There's your support system. There's statistics on all of this. So you factor in all of this, but there's also all those internal factors that impact how you make a decision. And not only internal, like how you're feeling, but relational, I would say. How does this new diagnosis affect your relationships and how your relationships affect treatment for the condition?
Including your relationship to yourself, of course, which is a big old subject. And then there's communicating these things that you're sensing and feeling to the team and to others too. Another world unto itself. But so complex stuff, tips of icebergs, but yes.
Tips of icebergs, and one that I think we often don't give enough attention to is financial aspects of a disease. And that's because I think that in medicine, we're all embarrassed by that because it's shameful in this country that we have to think about, can I afford to get sick and to get treated? But it's real. And I think given current world, we have to consider it. I'm working with a family now, a husband and wife, and he has a glioblastoma and has for 5 years. They have powerfully advocated for his care and kept him alive far beyond prognosis. They're doing immunotherapy once a month. Immunotherapy is not covered under their insurance, and they're spending half of their income on one infusion for immunotherapy. This results in food hunger at the end of the month for them. So these factors are real. And in that whole mish and mash of all the things that are going around when you're trying to decide, how do I proceed and what sort of treatment, I want to focus you on the next slide, please. The primary goal, because you can lose your primary focus with all the input coming in. And historically, in 45 years of working with people in progressive diseases and end-of-life care, most can identify a primary goal. Somebody might say, I know I have breast cancer and I'm going to die, but I want to live until to attend my daughter's wedding. This becomes the primary goal. And this goal might define your treatment interventions. Or someone may say, I do not want to go back to the hospital again. Under any circumstances, I wish to be home. This can become a primary goal. So I just want to make people aware that sometimes when you get lost in all the factors affecting decision, you might be able to identify the primary goal. And that primary goal sometimes might surprise you when you start thinking through what's really important to you and what really matters. And a lot of times it has to do with quality of life over quantity of life. Any thoughts on that, BJ?
Yeah, as ever, I feel my color today with you being sort of counterpoints. I don't mean it as such, but as sort of slowing down. Like one thing to note here, folks, is Tom's talk. This is how we, in a way, these forces are at work. Your feelings, your hopes, your wishes. But one thing to sort of say out loud is you need to say these out loud, either to yourself or to your team. It's amazing. Oftentimes, a treating physician may not ask you what your primary goal is. Our talk here is presupposing that you have one. So to set this table, continue to set this table a little bit, you may need to advocate for, even if you can get in touch with your primary goal, you may need to be the one to articulate it and to put it on the table. It often isn't requested. And then what ends up happening is the systems or the physician's assumptions for your primary goal slide into place, and off you go.
And I love that, to be able to articulate it. But I think you make a great point. To be able to articulate your primary goal, you have to know what it is. And I want to say right now, it's okay if you're not sure what that is. And part of the purpose of this talk is to tell people that their primary goal may change over time. And that's okay. So that's one of the primary emphasis I want to say is today your primary goal might be A, but in a little while, another primary goal could shift. Now, I want to present a case here. Clyde and Sarah are people I have been working with for over 2 years. And Clyde was diagnosed in his early 60s with frontal temporal dementia. Terrible disease. Both Clyde and Sarah, very high power research associates, researchers, famous people in their field. And Clyde's meaning in life is his thinking. And this is slowly being robbed of him. Early on in the process, Clyde and Sarah and I talked about his primary goal. This man was exquisitely clear. If I cannot think or speak, I do not want to live. And my follow-up is, does that mean you wouldn't want to go to the hospital? You wouldn't want to get IVs? You wouldn't want to go to the emergency room? You wouldn't want antibiotics if you got pneumonia? Because in frontal temporal dementia, most people die of aspiration pneumonia. So clear. I don't want any of that. If I have poor quality of life as I identify it, Clyde says he wants to die. The take home for me around that is over time, Clyde did decline and he had really a lot of struggle and he ended up in a dementia care unit. He is now on hospice care. He's not going to do antibiotics if he gets sick, all the things that we expected. But he also had a fair amount of agitation that needed chemical restraint or medical management for his safety and for his comfort. When we gave him that and titrated the dose up, he got sedated. And at about the same time, he took to bed and wasn't able to stand. And I said to myself, oh shit, we've over medicated this guy. That isn't good. And I had to sit back and process with Sarah, who was smarter than me, that that's okay because his symptoms are better controlled and it is aligned with his primary goal. So I think this is an example of, wonderful people teaching me to remember the primary goal.
Amen. I think I know the folks you're speaking of. And it's also a note to the subjectivity of all this, the personal nature of all this, the often the absence of a clear right and wrong. Um, it's right in the context of that person's stated wishes, which is a world within a world there. So we as people trained in science, we're apt to think objectively and to suggest that there may be a right way. Even the phrase over medicated suggests compared to what standard, et cetera. So
Mhm.
off we go. And it's just a good lesson that you and I and others constantly have to relearn, to not accidentally supplant someone else's wishes with our own, and just the subjective nature. And not only is there caution there for all of us, but it's also, let that be liberating. If there's, if there is no clear right or wrong, then the sort of stakes are lower. Then you can feel your way and stay in touch with yourself as the guiding force. So
I think that's perfect, BJ. And I love that you brought that up, that there isn't a right or wrong. Because I remember in you and I kicking this issue around, that was the primary motivator. And the truth is that two different people will have two different primary goals for the exact same diagnosis and physical condition. So it is the context of the disease progression and the wishes of each individual patient as to what that primary goal is. All right, Sonia, next slide, please. Having said that and presented wonderful, brilliant Clyde, who was exquisitely clear and never deviated in his wish for care, I want to point out that changing our mind is human. And I want to say that keeping the space available to rethink your primary goal can align yourself better to reality and it can just be a safer place to live. So in general, I run across a ton of people who will tell me, I have a diagnosis, and when I'm wheelchair bound, I don't want to live. I want to take a plane to Switzerland and end my life. And then they become wheelchair bound and they look around and they think, well, this isn't so bad. I can enjoy my family. I can be wheeled outside and sit in the sun. And they say, I want to die when I'm bedbound. And then they become bedbound and they look around and they once again change their mind. They realize that what they perceived as quality of life shifts. And so I want to encourage people to stay open, to not rigidify your primary goal. Another example of that is a beautiful man that I cared for who was a special ed teacher in his mid 80s named Sam. And Sam had supranuclear palsy, which is a brain disorder, nasty one, because it affects your vision, it affects your balance, it affects your neurostatus, but it keeps you usually alert and oriented. When I first met Sam, I worked with him and his beautiful family of a loving wife and three loving daughters who only wanted the best for their dad. As I was working with them, one of the first things that I always try to do is review the plan of care and ask Sam, with his family present, what do you want to do if? So I go through those things with Sam early on when I knew him, because I revisit this frequently. And Sam said when I first knew him, yeah, I want to go to the hospital. I want CPR. I want intubation. I want anything to live. So sort of the opposite of the general example of as someone declines, they adjust to their reality. As Sam declined, he didn't like it. He didn't like being bedbound, and his vision changed because of this damn disease, and he couldn't read or watch TV. And so progressively over time, as I would revisit each of those questions, he would tell me, yeah, I've thought about it and I don't want to go back to the emergency room. I'm comfortable at home. And then later he would say, yeah, I've thought about it some more and I don't, I'm not going to take antibiotics if I get sick. So this was a big change and needed a little negotiation with his family. And slowly over time, he became bedbound and he got referred to hospice because at that point, he had a progressive disease. He was well within 6 months, and his goals of care had shifted to sort of what hospice would consider acceptable for their admission. So he went to hospice. But Sam had one more surprise for us. Sam decided that he wanted to choose his time to die. And because he was lived in California and he was in a hospice program, he was able to use medically assisted aid in dying, MAID. And so Sam contacted the doctors, followed up with the hospice, got the medications to end his life, chose the date and time, and took the meds. So here's a fella who died very peacefully in his home, surrounded by his loving family. But I never might have predicted Sam would be the fella to choose medically assisted aid in dying when I first started working with him. This is a guy who was full treatment. So this is, I think, a good example of shifting goals of care. And when your primary goal shifts, you got to shift the treatment plan.
And I think I love, these stories are so good because I think from some point of view, we might be tempted to think, oh, they're so wishy-washy, or they just don't know what they want, or we can vilify others and ourselves sometimes when for our ambivalence and for our changing minds. But I think as you're pointing to us today, not only is that okay, it's to be celebrated. That's sort of, you, even into your death, even through illness, are subject to motion and learning and moving. This is not, you're never as static as you might feel. And so all that's available to you earlier in life, this sort of dexterity, remains available to you all the way to the end. And that is not a problem.
Mm.
That is something to be celebrated. That is you moving through the world and staying real. And if you're staying real, that means change is happening. So, and I love your resetting our thinking on this. This is yeah.
Well, I
Change
love
is sort
that
of yeah.
comment. I love that comment around staying flexible. Let's go to the next slide because it fits right into this. Grit and perseverance. Most of the medical literature refers to perseverance, but I've seen a few talk about grit. And I love the term grit because it's almost automata poetic. But what I'm talking about here is you've got a bad diagnosis, you've made a treatment plan. How do you persevere? How do you get through the tough stuff to obtain or to focus on your primary goal? So that's where we are. You got to have grit. You got to have perseverance. And if you aren't the person with the perseverance, I think it's good to ask who in your group of family and friends can hold that for you. Who can get you through when the going gets tough? Because a lot of treatments for cancers and other severe illnesses are hard. Not only are they pain in the ass to get back and forth to the doctor and get the treatments and the pains of IVs, but they make you sick sometimes, and they're hard to get through. So grit and perseverance are vital. They're the thing that gets you through. But I want to remind people that grit and perseverance sometimes is at the sacrifice of flexibility. Does that make sense? When you think about it, if you're full speed ahead on your primary goal and you're going to achieve this treatment intervention to achieve your primary goal, you sometimes can't look around to your world and see that there are other options because you're committed on a path.
Right.
So, yeah, it's like the question to ask yourself is how do you persevere toward your goal while remaining open to change and available to rethinking intervention? That's hard.
It's so hard. It's like so many things. It's sort of a little bit of this, but not too far. A little bit of that, some sort of middle way. You're balancing between the focus that grit requires, but that leads to myopia, as you're saying. That leads to crowding out so much of the world. And then so you zoom out, and then you see the whole thing, and that can feel like a very unfocused state. And so, to your point here, and you can't pick any one axis, any one character trait that will pull you all the way through. These are sort of points in tension. Because if I'm hearing you right, grit is an amazing force, really another thing to be celebrated. And like maybe anything left to its own devices can go too far and can pull you places that yank you out of someplace yank you down to some path you might not want to go because you just didn't dare to look up. So
Yep.
how do you do a little bit of both?
Yeah. And I think that grit is one of the places where people really get stuck. And I want to, and so it's really hard to zoom out because grit, by its almost definition, requires a laser focus. And so I was working with a very young man, a 32-year-old man dying of colon cancer. And he had two children, a 3-year-old and a 1-year-old. And his wife was the grit. She was going to get him through and treat him and make sure he survived, which is a beautiful, beautiful, loving thing. It was hard for me because he was dying and he had young children. And I wanted to help him leave a audio visual recording for his kids. And I wanted to have him have a goodbye to his parents and to his dear loved wife. But we never got there because his wife's perseverance in treatment resulted in him being intubated in an intensive care unit and dying there. And it's okay. But I think it probably will complex her bereavement. But she should feel proud of the love she gave him. Another example, a bigger example. There's a man named Dr. Jordan. He was the first president of Stanford University, turn of the century, 1890s. This guy is an ichthyologist, an expert in fish. Brilliant, brilliant man. He classified 1/5 of all the fish on the planet. The story of grit and perseverance comes because he had all his fish stored in a big barn and it burnt down. And he went about and collected all of the specimens from around the world that he could again. And he had all the fish stored in a camp on campus at Stanford University. And the 1906 earthquake came and destroyed all his samples again. And the guy rebuilt his specimens. This is a story of perseverance that was of great service to the world. However, Dr. Jordan misclassified a whole lot of fish because he had blinders on and he knew that things with scales that live in the water were fish. And even though he anatomically dissected certain fish and found that they had different anatomical parts and weren't necessarily correlated, he couldn't see it because of his powerful, powerful perseverance. He was going to get this done. And the final story about Dr. Jordan is he was one of the primary first adapters of eugenics in the 1920s, which is a horrid concept that there are different races of people and that different races are inferior to others. Of course, he was a white man. So I believe that type of racism comes from being unable to see the truth in your world. So that's my talk on grit and perseverance. It's tough. It's a value, but it can really limit your options.
Oh, it's a biggie. It's sort of like it's sort of like acceptance and fighting. Like it's like when to do which, or when to let go, when to hang on. is there, and I know that yet another thing that could be a whole other series of talks. But before we move off of the notion on grit and perseverance, any anything to say about how to assess when the grit's taken over, when you need to lighten that up, or when you need more of it, or how to know where you are on the spectrum at any one time?
That's a great question. I would say that overdoing grit may be related to the amount of suffering that you're having in your
Mm,
life.
mm,
And I'm not saying that I'm just thinking that uh, if you're suffering a lot and not getting a lot of feedback of value, like if you're going through all this chemotherapy and your scans say that your cancer is growing and you're going to persevere with a goal,
mm,
that could be a clue. Another clue is if you look
mm,
around and see that your goal seems to be very different from anyone around you, your spouse, your medical doctor, the nurses caring for you, if they're all like sort of implying, why are you doing
mm,
this? You may want to ask yourself.
mm,
The tricky thing about grit and
yes.
perseverance is people take appropriate pride in the fact that they're getting it done and that
Mm, mm.
they're helping get through. So it's a tricky one, BJ.
It
I think
is.
that one of the ways to do that is to look at the value of change, which is the
Mm,
next slide.
mm,
All right, so we were just talking about holding fast to the primary goal and not changing that. But what is the value of making a change? And I'm sure a lot of you can think about that. You know, changing your primary goal can allow you to align treatment to what is happening now, not what's happening in the past. And my experience has been that when people shift their primary goal and subsequently their treatment plan to something that is more realistic to reality, that it can lift the burden of having to live trying to obtain an unobtainable goal. And so your life might become lighter. You know, if we think back to the young man and his wife, maybe their life could have been a little lighter if they had aligned goals to his growing tumor. I don't know, but that's just sort of my thought on that. So my opinion is that shifting goals to reflect how you feel, what you think, what's going on, that can decrease suffering.
Yeah, beautiful. And I think what you're pointing us to here to celebrate this notion of change and move with reality as a value,
Mm-hmm.
as a way of staying up to date with reality, because that thing's always that thing reality is always moving. What you're doing too here, Tom, subtext here is de-shaming the idea of change. I think when I meet folks who, clients, patients, others, who have moved with, like it reminds me of David Bowie and his career, who, any one album, song, outfit, anything, it was always different. It was a work in motion. And right up to his death, his last album included his songs about his dying from liver cancer. So and yet we know him as David Bowie. There was a through line of him, even as he was changing all
Oh,
along. And
yeah, I like that.
there's some gorgeous, so yes, we are changeable, and yes, we are irreducible. There are through lines that make us all the way through, even as we change our outfits, literally and figuratively. And I think one thing that holds us back from letting ourselves do that is something like shame or embarrassment, or we want to be recognizable. I am Tom, I am BJ, I look this way, I am that way, I have these characteristics, etc. And that's true, but sometimes those things can hold us back. And why let ourselves be held back right and
Well,
that's around the
and
corner.
you know what I like about that, BJ, is that when you make a shift in change, I love that the through line of who you are, your soul through the whole thing. So, like, for example, Sam was full code, full treatment early, and later he did medical assisted aid in dying. He's the same Sam. There's a soulness to him that continues through over time. The point I wanted to make around the value of change is sometimes a short-term goal can be really meaningful, almost more meaningful than a long-term goal. So, like, maybe today's primary goal is having lunch with a friend. That's okay. And when it's a shorter term goal, it becomes obtainable and it becomes good when you obtain it, when you reach it, it's like satisfaction. I've accomplished something. So if you can shift your goals to something smaller and more attainable while recognizing the through line of who you are, I think that can have value. And an example or a possible example in this thing of the value of change and the way it sometimes looks is I'm currently working with a couple, Mary and Jack, and Mary has had glioblastoma for 3 years. And and her husband, Jack, who's very high power executive, both of them high functioning, high power, get it done, accomplish everything in life, which they have been incredibly successful at. They approached their diagnosis of glioblastoma as you would expect. Who are the best specialists? What's the best surgery? How do we proceed? She had surgery, the cancer returned. What are the best chemos? How do we proceed? She had chemo, the cancer grew, and then the cancer recurred a third time, 3 spots in her brain. She's getting progressively more frail. Mary says, I want to pursue treatment. I want to keep getting my chemo. The oncologist is saying there's very little chance this will make any difference for you. Her opinion, her soul, her through line says, doesn't matter, I'm going to do this. Jack is in the position of honoring Mary's wishes. Jack is at work, managing thousands of people, et cetera, et cetera. He gets called out of meetings frequently because Mary's supposed to go get her blood drawn so she can get chemotherapy, but Mary doesn't want to get out of bed. And so she misses her blood draw appointment and subsequently misses her chemo appointment. I think the thing to ask here is what's changed? And I think maybe Mary is speaking to Jack and to everyone that her body can't do this anymore. And so that's a subtle change in a primary goal for Mary and helping Jack recognize that things are different can help him relax a little. It's like, oh, okay, you can't do this. It's okay. She can still verbalize the primary goal of aggressive treatment, but her actions say, I want to be comfortable. All right, I threw that one in because it has to do with all the peculiarities of changing our mind, even sometimes when they're not verbalized. All right, another slide. Change in culture.
Mhm.
And I want to talk about the fact that our primary goals are directly influenced by our cultures. And by that, I mean our race, our family, our heritage, our community. And so we make our decisions based on who we are within our culture. And if we make our changes if we change our mind, that may go against some of the cultures, whether it's the religion or the community and the standard of practice. Maybe you change your mind and decide, I'm not going to do treatments, or I am going to pursue treatment. Whatever the change is, it might go against our larger community. And so I think it challenges us to ask, how do you deal with changing your mind and presenting that to the people you love and your community? Because a lot of times they'll align behind you on one primary goal, and if the goal shifts, how do they manage that? Something to think about. An example of that is my people I've been working with, John and April. And John, I saw a couple years ago when his mother was dying of brain cancer. And as we were able to transition her into hospice, and she died peacefully at her house with John as her primary provider. John's girlfriend, April, had her mother had a series of very severe strokes. And April's mother was completely bedbound and nonverbal. She was not able to swallow very well. She would gurgle all the time. And yet April kept feeding her and kept hospitalizing her and kept treating her with antibiotics because April's mother culturally specifically said, I want to be kept alive under any circumstance. And this is what April felt is best for her mother. It is the best expression of her love to her mother. But that's hard on John. Now, the treatments that John and April's mothers received are likely completely appropriate to the patient's goal of care. But it's causing conflict within the relationship as to how to relate to each other and how to support each other when the goals of care are so different.
So here too, you know, without the sort of clear right or wrong, there may be right within John or right within the culture, right? And what to do when these various sort of concentric circles are maybe in conflict.
Yeah.
Again, no real right or wrong.
No real right or wrong. And part of what today was just throwing out some of what these conflicts or pivot points can be for a person and how different people will resolve them differently. Mary might resolve it different than April, different than Sam, different than Clyde. So it's just something I think to consider and wonder about. Let's go to the last slide. Everything changes. And so ultimately, what I want to say about this is if everything changes, be kind to yourself. The only certain thing is that all this will change. And knowing this, doesn't it make sense that our primary goals of care might shift as our disease progresses? Change can offer us opportunities to reassess and to integrate what's real and present in our reality now. And it just might be a chance to calm down and to be present with yourself and the people that you love. So embrace change.
Oh,
Anything?
Tommy.
Yeah.
Oh, it's so beautiful. And you're making all the corollaries to what you're saying. Like as you're describing that, I realize and hearing my own questions, like how to do this. So much of the subtext of what you're teaching us about today and valuing change puts us back to the skill of listening to yourself, listening to the world around you, listening to people you love, as ways to know that anything's changing, as signals to read. And that's, again, yet another topic. How to read all these signals is tricky, but this sort of exquisite tuning in. And if you're exquisitely tuned in to yourself and others, you you will auto deduce that everything changes. But the skill, at least one of the skills, getting there to this sort of durable flexibility that you're pointing us to. One of the takeaways for me is just the exquisite act and art of listening, to help as a tool to do this.
Yeah, I love that. You're absolutely right. And you and I had talked about maybe another talk for the two of us is living in uncertainty or living with certainty. And I think it has some relationship here because we're always asked to make choices. We got to decide what to do. And you're living with uncertainty. There's no absolute answer as to which choice is the best one. So what I was trying to say in this talk was exactly what you're saying, BJ, is to be open to what's happening in your body and in your life and around you, and to constantly stay flexible as to what your goals of care might be when you're dealing with the uncertainty of a serious illness.
Amen, brother. You know, and especially in that context of decision making and the pressures of a medical clinic, et cetera. The other trait that you're pointing to is courage to listen and to act on this changing mind of yours. It's another piece of this puzzle. It's a very beautiful puzzle.
We talked about courage like 6 or 7 months ago, you and I. So
Mhm.
maybe that'll be the requisite to this one.
Yeah, it's another piece of glue.
Anyone? I think we can open it for questions or comments. Anybody? We have a few minutes. I thought there were some. I'm not sure.
Let's see here.
Let's see, we got a hand up. 1 second. Karen, you will have to unmute yourself on your end as usual.
I think I'm unmuted.
Hi,
There you
Karen.
are. Hi,
Hi,
Karen.
Tom and BJ. You guys are so massively good. Thank you. And Tom, thank you for sharing so many of your client stories, because I know this is where the truth of illness is tested. And I know for myself, I'm now over 3.5 years, I can hardly believe it, with stage 4 metastatic lung cancer with bone metastasis. And I'm a statistical outlier. My oncologist essentially is amazed, and I'm happy to be amazed. But
How
you
did
really,
you do that, Karen? How did you do that? Grit
well,
got
I'm
you through.
very careful with decisions. And I think in the first, after the trauma of diagnosis, I must say I ceded decision-making to a brilliant care team, a brilliant oncologist. I am just hugely blessed. I do not have one single barrier in my life to treatment, to access. I just have no worries. So I know that I'm unusual in that respect. But over time, I've recognized that the major decisions I've made when I've had 3 instances of disease progression with tumors in my vertebrae, lymph nodes, and in a rib, I needed help with decisions. And it became really important for me to identify, okay, who is my decider? Who really is helping me process all of this information? My husband, Steve, he's listening with me, was very good at reading the technical stuff. Are there clinical trials? My oncologist is brilliant. He's on the leading edge of research, no question. Kaski Shrai, and he has been wonderful. But when I think about decisions now, staying fluid, and the very last slide, everything changes. I wonder how you did a webinar once, holding expectations loosely. And I worry sometimes that I'm too loose. I want to be not too tight, not too loose.
Well, can I make an observation?
Oh,
And
please,
then
I'm
ask
trying
you a
to find a
question?
question,
Yeah,
but I
well,
can't.
no, my
Thank you.
observation has been over time that people early in their diagnosis often make their choices based on literature, advice from their primary doctors, statistics. Later on in their illness, I find that people make their decisions based on their heart and what they're feeling and what their family feels and how it's been. And so I think that's an interesting thing to consider is how we make our decisions and what's important in those decisions seems to shift. And that brings to me a question to ask you, Karen, is did your I mean, I spent a long time talking about the primary goal, and I sometimes wonder if that's sort of a term that doesn't resonate for people. But did your primary goal change over the course of your illness and the different treatments you've been through?
Tom, it's a good question. And yes, my primary goal did change. I think initially the trauma of a diagnosis of stage 3 lung cancer, it's the threat to one's mortality. And my primary goal was to live.
Oh,
It was very distinct. I simply wanted to live. And then I did that. I accomplished that goal. And then, Mettle, you're certainly involved here. Then the goal is, okay, what does it mean to me to live well? What is the difference between the existential drive and just living a good life in my community with family and friends, and kind of putting it together? My goals still change. I'm trying to figure out now, with stable lung cancer, but lots of side effects, if I can travel. I would like to get to Japan. It's one of my dreams. So that is a goal, but I think, gosh, hardly related to lung cancer, but completely defined by
well, it's
medical.
not related to lung cancer, but it's certainly related to you.
Yeah,
And primary goals, I love that if they're not related to the disease, but instead related to the person.
yeah.
And then you add up, is that a possible thing? And if it's not possible, do I need to shift what that primary goal is? Japan
Mhm.
sounds great.
Yeah, and I will turn this back over to Sonia, but thank you from my heart. I
Oh,
just, you are medicine itself, you guys. Okay, bye.
well, thank you for sharing. It's
Thank
really
you,
Thank you,
Karen.
Karen.
Bye.
Always so good to see you. Jeez Louise.
Hey, anyone, I know we have a small group here, but if anyone else has a question or just a comment on any of this, please feel free. We're also kind of just wrapping up perfectly timing wise here, so there's that as well.
Well, while we're pausing, I just want to sort of, as I was listening to Karen, always so provoking in a beautiful way. You know, it's tempting to think of this change as growth, um, which starts heading into something that feels like improvement or something. But I didn't hear, it feels like, and maybe the goals, maybe this sort of change that Karen you're describing over time, and what you described as sort of as a pattern, sort of early on in treatment, it's a little bit more abstract, a little bit more theory. Later on, it becomes more carved by experience and the felt universe, etc. As you were describing it, it almost sounds like you could sounds like a maturation, like growing with this illness, or growing up with it, or something. But I just sort of, I'm kind of just watching myself be a little torn. I want to see this as a sort of a progress, as growth, as a maturation. And in some ways, maybe it is. But that also may be a projection. Karen, I didn't hear you anything vilifying the earlier version of you making decisions versus this new and improved version. That may be part of the narrative too. But I guess my whole point is just to say also that change doesn't need to move vertically. We don't need to be getting better or worse per se. Or we can stay innocent into our death too. So maybe growth is happening, and that's wonderful. But we can still have growth irrespective of, or we can have change and evolution irrespective of improvement.
I kind of
Yeah.
compare it to, you have this new diagnosis. It's a little like having a new relationship. You learn the person
Yeah.
that you're dating, and then you mature into your relationship with them and all of their foibles. And
Yeah.
so yeah, I think I get your point that we're perfect as we are, and our
Mhm.
initial decisions and primary goals are fabulous. But as we deepen into our relationship with our disease, and it pushes us to consider the values in our life, we might make different decisions then.
Yeah. Yes. Just different. I like that. And Karen, I see your note. Maturation, that word lights up for you. I'm glad. It has that taste from here. And we've gotten to see you change and move over time. Part of this community you've been for a long time. So how cool. Well, Tom, thank you as always, man. I'm sorry to be late to you and
All right.
everybody else, but it's so easy to just away you go, brother. Always. It's so good.
Away I go. Well, it's always great to have you with me, BJ. And Sonia, thank you so much for the slides.
Oh, my
And
pleasure.
yeah, it's just always great to be here and be able to share some thoughts. It always makes me think of the next things I want to be talking about. So most likely Mettle will see
Mm.
me again soon.
And thanks everyone for being here. Wishing everyone a good, relaxing weekend. Thank you, Tom. Thank you, BJ.
Bye,
See you
guys.
soon. Bye.